Okay, let's unpack this. We are diving deep into, well, a pretty massive overhaul of head trauma guidelines. We're specifically referencing the NHG-Standard Hoofdtrauma update from February 2025.
Yeah.
Now, for context, the NHG standard, that's the key Dutch general practitioner standard, right? Updates like these, they really drive major shifts in first-line care, not just there, but often influencing things globally. Our mission today, really, is to filter out the most essential changes, the ones that redefine how you assess risk and manage recovery after someone gets a knock to the head.
And that context is absolutely crucial because we aren't just looking at data for, say, the severe cases you see in an ER. What we're doing is distilling the core changes that affect how the overwhelming majority of mild cases are assessed and managed right there in general practice. These guidelines needed custom tailoring. The immediate risk of something serious, like an intracranial complication, it's just inherently lower in that first-line setting compared to a big trauma center.
Right, different baseline risks. And before we even get into the sort of mechanics of assessing that risk, let me just drop the biggest, maybe the most counterintuitive bombshell right up front. For decades, someone bumps their head, the golden rule was set alarms, wake them up hourly, check on them. Well, that traditional waking advice, it's been reversed. Actively discouraged now. We are definitely going to dive into the evidence, or maybe the lack of it, that drove that reversal later on.
Yeah, that's a big one. But first, to understand the immediate risk, we really need to define the injury itself. Hoofed trauma, or head trauma, basically covers any direct or indirect injury to the head. The only exclusion is superficial facial injuries, sort of between the jawline and the eyebrow. But the real danger, the thing we're actually assessing risk for, is an intracranial complication. So that means any traumatic lesion inside the skull. Think brain tissue damage, vascular tears, that kind of thing.
Okay, so if the goal is preventing that complication, you need a quick way to identify the mechanism, the type of injury that created the highest risk. And that brings us right to this critical definition: high-energy trauma, or HET. Why is this label so vital?
Well, because if HE occurred recently, and the guideline defines recently as less than 2 hours ago, that fact alone instantly flags the patient as an emergency risk.
Ah, okay, so it's an immediate trigger.
Exactly. And HET isn't just, a big bump. It implies a massive transfer of energy. That kind of force risks severe hidden injuries, maybe spinal or internal injuries, not just what's going on in the head. And the specifics here are quite detailed. We're talking falls from a significant height.
How high is significant?
Defined as 2 to 3 times the person's body height, or an accident in a vehicle going over 45 kilometers per hour, even if they were wearing a seatbelt. Also, a car hitting a cyclist or pedestrian at a speed difference over 10 kilometers per hour.
Wow, that's specific.
It is. Or even a motor vehicle hitting a cyclist or moped rider with a speed difference over 35 kilometers.
It's that level of detail I find really useful for a practitioner, The source material is also very clear, for instance, that just falling off a changing table, generally not considered HET. The whole risk assessment seems built around the physics of the impact.
Precisely. And, while most of these cases thankfully turn out to be mild, the sheer number of head traumas overall is quite high, about 22 per 1,000 patients per year. You see peaks in the very young, kids under 4, and also in the very old, say 85 and up. But here's the really key number for this guideline. Only about 10% of all those cases actually get referred on to specialized care. So these new risk tiers, they're designed to make sure that critical 10% gets identified correctly and, importantly, immediately.
Okay, let's get right into that identification system now. The sources break down the risk of those intracranial complications into 3 clear tiers: strong, moderate, and lightly increased risk. This seems like the core operational framework for that immediate assessment.
That's right, starting at the top. Strong or emergency risk factors. If a patient walks in or is brought in with any one of these, it's an immediate referral to the hospital. Call an ambulance. The list starts with reduced consciousness, quantified as an EMV score less than 15. Now, for those maybe not familiar, the EMV scale is the Dutch standard, basically equivalent to the widely known Glasgow Coma Scale, or GCS.
Okay, that clarifies the terminology. Good.
Yeah.
What else puts someone straight into that emergency tier?
A post-traumatic seizure, that's a big red flag. Also, that recent high-energy trauma we just defined, if it happened less than 2 hours ago. Any suspicion of a focal neurological deficit, so things like double vision, problem speaking, maybe loss of movement in a limb, and finally, any clear signs pointing towards a skull fracture. That could be something you can actually feel in the head, or those classic raccoon eyes, the orbital hematoma, which suggests a skull base fracture, or blood behind the eardrum.
Got it. That's the list where there's no debate, just immediate action. So next down is the moderate risk factors. And you mentioned this is where some key updates really shift the clinical picture, especially around medications.
Yes, exactly. For adults, defined here as age 16 and over, the moderate risk tier includes persistent or recurrent vomiting. That's pretty standard. But crucially, it now covers the use of any anticoagulant medication. Full stop. So we're talking direct oral anticoagulants, the DOACs, vitamin K antagonists, VKAs, or even low molecular weight heparins, LMWHs.
That's quite a significant blanket rule, isn't it? Putting all anticoagulants in the same moderate risk basket. I noticed the standard mentions that while some clinical evidence might hint DOACs are lower risk than VKAs, the guidelines prioritize the underlying mechanism. Is this basically a better safe than sorry approach? Because any bleed gets complicated fast with these meds?
That's precisely the thinking. It's based on the pathophysiological reality. If a bleeding complication does happen, doesn't matter which drug type, immediate management is critical and needs specialist care. So moderate risk it is. Also in this moderate tier for adults, experiencing retrograde amnesia, that's memory loss for events before the trauma if it lasts longer than 30 minutes.
Okay. And what about for children under 16? What puts them in the moderate risk category?
Similar things, but slightly different focus. Persistent vomiting is one. Also, any clearly altered behavior, think agitation, kids asking the same questions over and over, being unusually slow to react. The use of anticoagulants, if relevant, is also moderate risk in children. And importantly, any suspicion of child abuse automatically puts it in this tier.
Right. Okay, moving down to the final category.
Yeah.
The lightly increased risk factors. You flagged this as having two major threshold updates.
Correct. First off, the age threshold for being considered at lightly increased risk just due to age, that's been raised from 60 up to 65 years.
Interesting. Reflecting maybe shifting demographics or possibly better health in that older bracket.
Could be a bit of both. The other maybe update is this new focus on specific antiplatelet medications. And this is a huge shift, really, considering how many people take these drugs.
Okay, so what's the nuance here?
It is a critical nuance. The standard now specifically includes the use of dipyridamole and certain pTOY12 inhibitors, drugs like clopidogrel, prasugrel, and ticagrelor in this lightly increased risk group, but only for adults. But here's the absolutely vital exclusion. Acetylsalicylic acid, that's aspirin, and carboxylate calcium are explicitly excluded from this risk category.
Wow. Okay, that's huge. So someone taking, say, a daily low-dose aspirin for their heart health bumps their head, they are not automatically put in a higher risk tier just because of that drug alone. That must cut down on a massive volume of potentially unnecessary referrals.
Absolutely. It's a very significant clarification. Other things that count as lightly increased risk factors for adults include any past loss of consciousness related to the event, even if brief, one-time vomiting, a severe headache, or one that seems to be getting progressively worse, anterograde amnesia, that's the memory loss after the trauma lasting longer than 2 hours, or being intoxicated with alcohol or drugs at the time of assessment.
Okay, so we have these three tiers: strong, moderate, lightly increased. What's the practical rule then? How do you use these to decide on referral?
It's pretty straightforward. Anyone with a strongly increased risk factor goes straight to the hospital, immediate referral. Then, anyone with a moderately increased risk factor also needs referral or at least specialist consultation. And here's the key multiplier. Anyone who accumulates 3 or more lightly increased risk factors also gets referred or needs consultation.
Ah, that stacking rule. 3 or more light factors bumps you up. That forces a careful calculation. Okay, now let's shift gears. Let's talk about acute management for that vast majority of patients who don't need immediate emergency care. The advice here sounds like it's fundamentally changed, moving away from just telling people to rest passively.
Absolutely. While we still advise that the patient probably shouldn't be left alone for the first 24 hours, mainly just to ensure any deterioration is noticed, and especially in children, by the way, if deterioration happens, it's usually within the first hour or two after the trauma. But the advice on activity is definitely different. Yes, rest is needed for the first 24 to 48 hours, but complete bed rest is now actively discouraged.
Right. Why the pushback against prolonged rest? That used to be the standard advice, didn't it?
It did, but the thinking has evolved. Lying in bed for, say, longer than 3 to 7 days can actually significantly delay recovery. It can even promote negative psychological feedback loops. The advice now is much more about facilitating a gradual return to normal activities. School, work. Aim to get back after a maximum of 2 or 3 days off, even if some mild symptoms are still hanging around. Activities should be built up based on symptoms, of course, and naturally, high-impact stuff like contact sports. Only once symptoms are completely gone. We also strongly advise patients to avoid alcohol and drugs in those initial days. It just muddies the clinical picture and makes observation really difficult.
Okay, and now let's tackle that traumatic change we teased earlier, the waking advice reversal. The standard uses the term Haydenhide, advising caution regarding the old waking advice, the WIC advice. This must be a huge relief for caregivers, but why did the medical community finally abandon this practice that's been around for decades?
Well, quite simply, because there is zero scientific evidence showing that waking advice actually speeds up the detection of intracranial complications, or that it positively influences the management plan in any way. The old recommendation check hourly for the first 6 hours, then every 2 hours after that was incredibly intense. It caused severe sleep deprivation for everyone involved, the patient, the caregiver, and honestly, the compliance rates in reality were notoriously low anyway. Basically, it created a lot of stress without any proven clinical benefit.
So the core message now for caregivers is, keep an eye out for genuine signs of deterioration. Increasing confusion, a really severe headache, repeated vomiting, but don't sacrifice everyone's sleep trying to stick to some unproven hourly schedule.
Precisely. Focus on quality observation of actual symptoms, not just ticking boxes on a schedule that lacks evidence.
Makes sense. Before we move into the longer term, just quickly, screen time. We've all heard the warnings, right? Limit phones, computers after a concussion.
Yeah.
What does the evidence actually say now?
Yeah, the evidence quality here is, well, unfortunately still very low. But the suggestion is kind of still there. The thinking is that considering limiting screen time, TV, computer, phone, video games for a few days might potentially shorten the recovery time by a few days compared to just unrestricted use. But it's definitely a soft recommendation, not some strict mandate based on strong evidence.
Gotcha. Okay, let's move on to the long tail of recovery. Most people, thankfully, bounce back pretty quickly, within weeks. But what about that group, maybe 10 to 15% of patients, particularly in specialized populations, who experience symptoms persisting longer than 6 weeks? What's going on there?
Yeah, that 6-week mark is kind of the threshold where we start thinking about persistent symptoms. The cause isn't always clear. It's usually multifactorial.
Yeah.
Could involve some level of minor brain damage, sure, but also environmental factors, patient-related factors play a big role. The symptoms tend to fall into 3 buckets: physical, cognitive, and psychological.
Can you maybe highlight a specific physical symptom that's often overlooked or misunderstood?
Dizziness is a really common one, and often a specific treatable physical cause is missed. A significant chunk, somewhere between 21% and 35% of dizziness after trauma, is actually caused by benign paroxysmal positional vertigo, or BPPD. And the good news is, once you diagnose BPPD, it's often treatable with specific physical maneuvers like the Epley maneuver. Other common physical symptoms include chronic headache, neck pain, sensitivity to light or sound.
And what tends to determine whether someone gets stuck in that prolonged recovery phase? Is it always just about how bad the initial injury was?
Not necessarily, no. Often, the factors that negatively influence recovery aren't directly related to the injury severity itself. Pre-existing conditions matter, things like migraines or mood disorders like anxiety or depression. Having had previous head trauma also plays a role, but perhaps the strongest predictor, according to the evidence, is often an inadequate or passive coping style. People who tend towards catastrophizing, avoiding problems rather than facing them, focusing excessively on negative thoughts, or failing to actively try and re-engage with normal function. For kids, pre-existing behavioral issues or family problems, and also lower socioeconomic status, unfortunately, seem to be negative predictors too.
So managing that long-term recovery sounds less like just treating an injury and maybe more like managing a whole shift in behavior and environment sometimes. If symptoms are still there past that 6-week mark, what are the recommended paths or referrals?
Well, the core goal is always finding that balance between rest and activity, what we often call energy management, and really encouraging a return to normal function. So for persistent physical or cognitive complaints, especially if there's fear of movement or just general activity avoidance, a referral to a physio or exercise therapist is often considered. They focus on activation, on graded exposure, using time-contingent treatment rather than symptom-contingent to help overcome that fear and build tolerance.
Okay. And what about those really common complaints of just overwhelming chronic fatigue or feeling easily overstimulated?
That's often where an occupational therapist, an OT, comes in. They're really skilled at teaching concrete strategies for energy management. things like pacing, prioritizing essential activities. And they also teach cognitive compensation strategies, ways to handle daily limitations in memory or concentration in a more structured, less frustrating way.
Now, regarding psychological interventions, the standard includes a really interesting, almost cautionary note, doesn't it?
Yes, it does. There's specific caution advised regarding launching into intensive psychological interventions purely for fatigue, cognitive issues, or psychological complaints that seem to be direct consequences of the trauma itself. The evidence for the generalized effectiveness of things like CBT, just for those post-concussion symptoms when they stand alone, is actually quite low. These higher level interventions seem best reserved for situations where you identify clear underlying barriers, like significant pre-existing anxiety or depression, or if that inadequate passive coping style is really prominent in hindering recovery.
Okay, so wrapping this up, what does this deep dive really mean for you, the listener? You've now got a complete update on risk management for head trauma, and it's clearly evolving away from some of that older, overly cautious, maybe passive advice.
Yeah, I think the core message is about having confidence in the triage process. You have this new clear framework. You've got the updated risk calculation, remembering that age shift is 65, the specific inclusion of certain antiplatelets, but importantly, the exclusion of aspirin. And you have practical advice that actually promotes early gradual movement and definitively rejects that intense, unproven, mandatory waking advice. It empowers a more active recovery.
Absolutely. And as we close out today, here's maybe a final provocative thought for you to consider. While these modern guidelines give us a pretty clear medical timeline for acute recovery focusing on that 6-week window, the source material itself strongly suggests that behavioral factors, socioeconomic factors, coping styles, these often predict who struggles long term, sometimes even more strongly than the severity of the initial physical injury. So it really begs the question, how much of successful long-term recovery is purely a medical intervention, and how much is actually about helping the patient successfully navigate and manage the complex psychosocial environment that inevitably surrounds a trauma like this? Something to think about.